Good morning. Good morning. It's an absolute pleasure to be here here in Knoxville and to be part of the team at the University of Tennessee, Knoxville. And thank you for having me. I look forward to meeting you all hopefully soon, and then in next year when we can meet in person, hopefully. Anyway, I'll be talking about surgical treatments of Parkinson's disease, specifically neurosurgical treatments, some of the history, where we are, what we know, and where we're going. So here we go. I do not have any disclosures. Very simple, straightforward. So some of the learning objectives today, we're going to talk about quite a few things, but one of the things that I want to go over and I'll reiterate and belabor are who are the ideal candidates for deep brain stimulation in patients with Parkinson's disease, and then what are our goals? What are we trying to treat with in patients with Parkinson's disease, and specifically what symptoms do we expect to improve and which symptoms we do not expect to improve. Here are our pretest questions. I'll give you a second to go over those. There'll be a chance later to answer these as well. Okay. Let's see how you all do. Just read these and then think about them. Don't phone a friend just yet. Okay, great. You'll get another chance to go over those. Let's go ahead. So, as Dr. Barbu talked about, the modern description and description, or modern classification and description of Parkinson's disease is just over 200 years, but aspects of Parkinson's disease have been described in all cultures since antiquity. But the modern period, we would say, started with a description from Dr. James Palsey's Parkinson's shaky palsy, he was a physician in London who described some of the sine qua nons of Parkinson's that we look for today, specifically resting tremor, a quote from his essay on a shaky palsy, being even checked by the adoption of voluntary movement, being that there's a tremor when the patient goes to move, the tremor resolves or improves. The gait, he noticed, the legs are not raised to the height which the will directs, meaning a shuffling gait. We certainly see that, and unfortunately some of you may be experiencing that as well. He described the non-motor symptoms. He described the problems with sleep, the problems with constipation. He did not describe bradykinesia rigidity. This was later described by Dr. Charcot, who then attributed and named the clinical phenomena disease after Dr. Parkinson. So what have we learned since that time? So over 200 years since this was described, we've learned quite a bit about both the environmental and genetic factors that contribute to it. And as far as environmental, we know that if you have a history of head trauma, that you are at higher risk for Parkinson's disease. We know that if you're exposed to pesticides, you are at an increased risk. We know that there are some environmental aspects that are protective, specifically drinking coffee, which I'm very pleased. I like to drink coffee, so I will continue to do that. We also understand the genetics of Parkinson's disease a little better. Certainly there are genetic or early onset Parkinson's, which will have a very direct genetic component, but there are multiple genes where that are contributing to the disease itself. But by far the highest risk for Parkinson's disease is simply age. As we age, our risk of developing Parkinson's disease is higher. And so as the population in the world and in this country ages, this is something that we're seeing more and more common, simply because as we age, our risk of developing Parkinson's disease increases. We understand the pathology. We understand that as we lose cells, specifically in the substantia nigra with dopamine, that we have more and more symptoms. This is why this is a gradual process. Most of the symptoms do not occur until a significant portion, the majority of those cells, are already gone. And so that is why we see this long prodrome. And typically, not all patients, but typically, patients can have a very, very long course. And in retrospect, Some of these symptoms can go back decades, not always, but sometimes. So we understand the pathologic reasons why this occurs. We understand that as there's loss of dopamine or dopaminergic cells, that this causes abnormal firing or abnormal activity in circuits. We have the pyramidal system, which is our motor system, and then we have our extrapyramidal system, which is described here, a complex system that we have all looked at and gone over multiple times, and whether we completely understand it or not, we know that as we lose dopaminergic cells, we then have abnormal function of some of the checks and balances in this system, which then presents as the symptoms that Dr. Parkinson described. We have the resting tremor, rigidity, shuffling gait, and then the non-motor symptoms as well. So as long as this has been described, certainly in the modern era of Parkinson's disease, surgery has been used in an attempt to improve the lives of patients. Early on in modern history, the most bothersome symptom to patients was the tremor. If you can imagine, over 100 years ago, 150 years ago, while certain medications were administered, that we were not in the modern era of dopamine replacement. And so medications were not as near as effective as they are now. And so surgeons would be employed to attempt to alleviate patients of, and usually this was not the negative symptoms, meaning the rigidity or bradykinesia, but the positive symptoms of Parkinson's disease. So you can imagine patients with horrible resting tremor. These would start with, even in some cases, lesioning peripheral nerves to have a limb stop tremoring. This, in addition to even resecting cortex. And all of this was, the patient would experience weakness or paralysis in some cases, but that was, in some cases, preferable to having an uncontrollable tremor. As the surgeries were performed and anatomy and medicine advanced, so did the treatments. As patients had better outcomes and what we call the extrapyramidal system, which is the basal ganglia, the globus pallidus, the thalamus, were targeted, these patients, it was found that surgical procedures could be performed on them without causing the weakness. One of the treatments performed was a pedunculotomy, and this would involve the patient being under general anesthesia and the surgeon going in and actually causing a small lesion in the cortical fiber, in the fibers that went into the brainstem and into the spinal cord. And during this procedure, Dr. Cooper actually avulsed an artery inadvertently. This is a desperate situation at best, and he believed he was able to control the bleeding, but closed, did not perform his pedunculotomy, and I assume did a lot of hand-wringing and then went to see the patient after the surgery was aborted, and he found that not only was the patient moving and quite well, but their tremor had stopped. And so what they found was, several years later, after the patient autopsy was performed on the patient, they found that he had actually injured the anterior choroidal artery, and this had given a very small stroke in the basal ganglia, which spared function but stopped the tremor. And this gave an insight, much better insight into what targets could be used in the treatment of Parkinson's disease. This is not too uncommon to some of the, we do not, certainly we rely on autopsy, but this is, we are using some of this information now to look for additional targets for deep brain stimulation in patients that have tremors or other maladies. They have a stroke of some sort. They then have an MRI after they've had resolution of their symptoms, whatever that may have been, and we can help understand, it helps us to understand the brain better and to find potentially additional therapies. So this was a treatment for quite some time. However, this was not because of the variable blood supply to the basal ganglia. This still had a very high mortality, but was the best treatment at the time. As surgical technique improved and there was better understanding of stereotactic frames. Stereotactic surgery is where, or the definition or principles of stereotactic surgery are to map out every square millimeter of the brain into a three-dimensional space and then be able to directly target extremely small areas, and in doing so, you can avoid trauma to the brain and you can reach very deep areas within the brain. This has a long history, and the modern, or the earliest stereotactic area rather, was in the late 40s to late 60s, and this involved targeting the same areas in the brain that had previously been targeted with ligation of vessels, targeting them with placing a stereotactic frame, then targeting them with needles, and then causing either a thermal ablation or injecting some sort of high concentration of alcohol to create basically a small stroke. And this, what would often happen would be that patients would have better or worse outcomes, and afterward, as the imaging at that time was, compared to now, quite rudimentary, that an autopsy would reveal where the treatment had actually been delivered and then correlated to the patient's outcome. This is also how we discovered after an autopsy that the thalamus can be targeted and was targeted for quite some time in the treatment of tremor in Parkinson's disease. And so this was advancing, but as the discovery and implementation of levodopa really took hold, and the success stories from the 60s, people moved away from surgery. I certainly, if there's a pill I can take and I'm doing very well and having great outcomes, I would rather not have surgery. And so this has basically shut down a lot of advancement and development of stereotactic and functional neurosurgery during that period, especially for movement disorders. As patients lived longer and as their disease progressed, as we know, as your disease progresses, you start to get more and more motor fluctuations, meaning that as you take the medication, you have an on period, but as your disease progresses, you need to take more and you start to have side effects and then a longer off period. And that's what brought back basically interest in functional neurosurgery in the early 90s and to try and address the problems patients were having with motor fluctuations. And that's what's brought us to our modern DBS era. During the ablative surgery era, it was placing a probe into the brain and then using basically heat at that time to cause a small stroke, similar to how they had done 50 years before, with a little bit, certainly a better understanding of the anatomy and then a better understanding of imaging. So that brings us into, deep brain stimulation. You can see that since 1997, these are the publications for deep brain stimulation. As far as the publications for deep brain stimulation in Parkinson's disease, those are in red for DBS, and then other therapies. This has really been the focus of functional neurosurgery, at least in movement disorders, for the last 30 years, and a true success story. So what is it? It was first described in the 1950s for chronic pain syndromes. Again, as we mentioned, as levodopa had that a real miracle to patients with Parkinson's disease. That focus went toward the medications and away from surgery. And then as patients had longer progression of their disease, additional focus returned to stereotactic surgery, functional surgery. In France, Benabib and Pollock were the first to report the placement of a deep brain stimulator in the VIM, ventralis intermedius nucleus in the thalamus in Parkinson's disease in '87. And then again, they reported the use of deep brain stimulation in the subthalamic nucleus in 1993. Both of these are involved in the abnormal circuitry, but certainly the subthalamic nucleus and the globus pallidus in Parkinson's disease are going to be involved in all aspects, and we'll go over that a little bit. Both of those, it took the FDA here in the US about 10 years for each of those to approve those treatments for deep brain stimulation for Parkinson's disease. So who is going to be an ideal candidate for Parkinson's disease? And who can it help? So certainly one of the most important things, and if not the most important, when we're thinking about who can be a candidate is, do you have Parkinson's disease? The reason is that if you do not have Parkinson's disease, and rather you have say a Parkinson's plus syndrome, either supranuclear palsy or multisystem atrophy, though the success rates and how we're counseling you as far as your expected outcome do not apply. So we need to be certain, and this is why it's so important that you're under the care of an experienced team to actually get the diagnosis right. It's, I believe on first encounter, the diagnosis is usually right about 80% of the time, and as time goes by, that certainty increases. So that's one of the first things that we want to establish is to first get the diagnosis correct. The next is patients, we need to see that they actually respond to dopamine replacement. Typically, we look for a 30% improvement in their symptoms, but and then we want those patients to have side effects. Not that we want people to wait forever until they're incapacitated by the disease, but if you're taking the medication, you're not having any side effects from the medication, and you're not taking the medication, say, every 2 hours, it may be premature to think about surgery. Certainly as a surgeon, I want to know that I'm going to make you better, and certainly those are some of the things. So patients, we want them to, first of all, respond to dopamine replacement, and that predicts success with deep brain stimulation, and then that they're having some sort of motor fluctuation, meaning that your on period is shortening, your off period is becoming longer, or you're having dyskinesias due to your dopamine replacement. Every patient that we consider for deep brain stimulation, we have them see our neuropsychology colleagues to assess for dementia. The reason is that this is a very involved process as far as coming back, surgery, occasionally awake, in addition to coming back from multiple programming sessions. And so that can be something that if people are struggling with dementia or memory issues, that can be a very difficult endeavor. In addition to, we know that patients that have cognitive issues going into surgery are at increased risk for declining after surgery. Other things we want to make sure is that certainly depression, anxiety, mood disorders can be associated with Parkinson's, and we want those to be treated. You may still have a level of depression or anxiety. Not that if you have a low level, it does not mean that you would not be a candidate, but certainly we want to make sure that those are treated and considered before undergoing any surgery. So how does it work? This is a question that, as we learn more, it seems that we become more and more interested and even perplexed. Initially, we thought that we were just causing a micro lesion in the brain or a reversible stroke, meaning that we were placing an electrode and then creating an electrical field that was then simulating a stroke in the brain that was reversible. As you turn off the electrode, that interference stops, and then we thought the neurons function normally. When you turn off the stimulation, they do function normally, but we understand that we're actually causing some inhibition or some excitation, and so it is complicated. But as we know that we are influencing the local environment in multiple ways, including some of the supporting cells, not just the neurons and axons. So again, what is the goal? What are we trying to achieve for patients? We would say that certainly if patients, as we said before, have a diagnosis of Parkinson's disease and they respond to levodopa or dopamine replacement medications, then, and they're having side effects, that they are indeed candidates if they do not have any of those other contraindications. And so what we're trying to achieve, we would typically say that deep brain stimulation is going to improve the motor symptoms of Parkinson's. And so this was the VA study that had a randomized controlled trial. This was published in 2009, and basically what it showed was, compared to best medical management, that the patients that had deep brain stimulation as opposed to the medication group had about a 5-hour increase in their on times without troubling dyskinesias. And so instead of trying to remember all the things that it may or may not improve, one simple way, and this is a generalization, would be to say, if your medications improves those symptoms, then deep brain stimulation is likely to improve those or should improve those as well. And that's one way to think about it. And so what are the risks? And so certainly this is surgery. We do not take it lightly. There are some risks with deep brain stimulation. There is a slight risk of hemorrhage. That is the most worrisome complication of surgery. This would be any hemorrhage of 2%. Having a significant hemorrhage which had a permanent neurologic sequelae, meaning that you were injured by this, is the equivalent of having a stroke. It could be life-threatening, but the rate of that is well less than 1%, though that risk is there. There is a slight risk of infection. I would say that this is, while most of our data and most centers are less than 2%, it is a frustrating portion because anytime you implant a device, there's some risk of infection, but that risk is relatively low, and that it's improving all the time. There's a small risk of seizure, small risk of hardware malfunction. This was with some of the older hardware. I would say that certainly anytime you have a man-made device, it can fail, but the devices are improving in addition to the durability. There are also some stimulation side effects. So when we place the electrode, we're placing it within a few millimeters of additional pathways that, as we turn up the stimulation, that we can influence. So if we're too close to the cortico-spinal tracts, that we could have you could have pulling, you potentially could have some cognitive issues, you could have worsening depression, anxiety, worsening speech, or worsening balance. And again, that's why the programming sessions are so involved and are designed to maximize your therapy while minimizing any side effects. So how do we actually place these electrodes? So the stereotactic technique here, we have a Lexel frame. This is one of the newer iterations. There's one newer than this, but basically most of the techniques involve placing a stereotactic frame on the head. This does two things. This keeps the head still while the electrode is being placed, in addition to allowing a rigid platform which our imaging, here we have on the right, will map out every square millimeter of that volume within the frame and will allow us to accurately place electrodes. You can see there that when this started, that's a ventriculogram. Previously, the ventricles or the fluid-filled spaces in the brain had to be injected with dye, and an X-ray was performed in order to identify the midline structures and to indirectly target our nuclei. Now, with MRI, we are able to see the majority of our targets, and we're able to do direct targeting. Here, if we look at how we used to do this, again, most of this was based off of atlas descriptions, and the atlases were based off of only a few cadavers. And you can imagine that there is variability, as there is in everything. Now, we don't use the atlases as much. We use your MRI, which is the atlas of your brain. And so this has allowed us, once again, to directly target the structures that we are intending to place our electrode to, rather than using indirect targets, which was the mainstay for decades. Again, here we have a patient where the frame has been placed, the head is immobilized. This patient, you can see, is awake, and that allows, in some cases, physiologic confirmation that the electrode is in a satisfactory location, and we'll go over that as well. So why do we go through so much care to ensure that we are in the correct place when we're placing deep brain electrodes? Well, the reason is we know that millimeters matter. These structures are, depending on the target, the size of a lima bean or even just bigger than a pea, and so we know that being off by even 3 millimeters can be the difference between someone having improved symptoms and someone not having any improvement or any benefit from the surgery. Again, and so how do we do that? We talked about our stereotactic technique, and there's a couple ways. Again, we can confirm after we place the electrodes now with intraoperative imaging to ensure that we are indeed in the intended location for our electrodes. We now understand very well where we need to be with our electrodes, and this is done in the operating room now. The other way that we can confirm that we're in the correct location is with physiologic confirmation. One of the ways and one of the mainstays, certainly even as I began my career 15 years ago, one of the mainstays was microelectrode recording, where you pass a microneedle through the brain, listening to all of the cells on the way down, and then looking for the specific firing patterns of the target you were looking for. This, the other way would be to actually place the electrode and do macro stimulation, where we place the electrode and turn on that electrode to actually test the patient in the operating room and to look for, one, efficacy to make sure your tremor is improving, your rigidity is improving, and your bradykinesia is improving, while also ensuring that you're not having significant side effects, such as to your voice or pulling or numbness and tingling that persists. And those are the two physiologic ways of telling that we're in the correct place. So both of these, one of the ways in all centers are done in the operating room. So we leave the operating room doing everything possible, knowing that we have placed the electrode in the correct place. And again, multiple ways to do this. We can place our electrodes and get an intraoperative CT. We can keep the patient if they are asleep. One technique is to take the patient to the MRI scanner and obtain an MRI to ensure they're in the correct place. And also there is a MRI guided system now where the actual electrode is placed to target under direct MRI imaging. And so this allows you to actually compensate and change your trajectory. So, and as we're doing this and relying more and more on imaging, we do not require that the patients be asleep in many of the cases, which is certainly good news. This is an exciting time also. In the last 5 years here in the States, a little longer in Europe, we've had directional leads. We know from our paper we looked at earlier from UCSF, we know millimeters matter, and that we're surrounded by other structures that we could potentially cause side effects for. And now we have multiple companies here in the US that have directional leads, meaning that you can see here on the left, we have one of the older contacts or leads with 4 contacts that certainly gave us programming options. But if patients were having disturbing side effects, it was difficult or more challenging to program those patients. However, now with directional leads on the right side, the directional leads that we now have available have 8 contacts, and we can shape the charge and the electrical field to try and minimize those. And so once again, and it gives us more options, hundreds of thousands of options really for programming. The future of DBS is very exciting. The hardware is already available for closed loop stimulation, meaning that right now we have open loop stimulation, meaning that the actual device is just delivering therapy. It is not necessarily listening to your performance or your symptoms or your biomarkers, but now we have hardware that's readily available where we are measuring either patient's tremor with a wrist unit that can then modify delivery, and then we also have sensing of the brain that looking for beta band or abnormal activity, and using that marker to then shape treatment. Very exciting. High resolution electrodes, again, being able to shape our treatment field and basically just treat the tissue that we want to treat. And then miniaturization. Even, again, in the last 5 years, the devices are getting smaller and smaller, and this will continue. So one of the other treatments that I had the pleasure to take part in was not exactly this was in the 50s, but one of the things that's new for Parkinson's patients and essential tremor is MR-guided focused ultrasound. So this again is an older technique. This is actually an article from the 50s from where you can see there on the left there are 4 ultrasound arrays that are focused together, and similar to stereotactic radiosurgery, you're taking 4 arrays that are then focusing on a single point where they meet, can have an increase in energy and damage a small amount of tissue. With 4 arrays, so you can see here the patient was fixed. These cases required a craniotomy. They would take a very long time, and this was an experimental treatment that really didn't have a real clinical application. So it died away and was basically in the dry lab or in the wet lab in research institutions until about a decade ago, when we had the development of better MR imaging. Here in the center there, B, that's MR thermography, and what that allows us to do is when patients are in the MR scanner, we can watch and we know exactly the temperature of the area that's being targeted. And now instead of 4 arrays, we have over 200 arrays that then focus on a single spot, and we can gradually turn up the temperature of the tissue, and we understand now what the temperature is and how long we need to heat up the tissue in order to cause a reversible versus an irreversible lesion. And you can see in C, the patient there has a small area of swelling where a thalamotomy has been performed, and this would be a patient with either essential tremor or Parkinson's disease. There have been now, currently it's only FDA approved for treatment of patients with essential tremor. It has been, and where I was previously, there have been published trials for patients with either Parkinson's, either tremor-predominant Parkinson's, and trials with unilateral globus pallidus internus, or I'm sorry, Parkinson's disease, but unilateral pallidotomies, meaning targeting the globus pallidus internus. And certainly with patients that had thalamotomies, as we talked about, these targets have been around for multiple decades. We saw improvement of tremor. The difficulty is, as you recall, before deep brain stimulation, the reason deep brain stimulation became such a popular treatment was, 1, it was reversible, and 2, you could do it bilaterally without causing some of the problems that bilateral lesions cause. Now we know from our pallidotomies, when we would place electrodes, or rather probes down and cause small lesions before deep brain stimulation, we knew that there was an increased risk of cognitive problems, speech problems, balance problems. And so currently, this is only offered for unilateral treatment. There are trials currently in Japan for bilateral treatment. There's a treatment for subthalamotomy, which just closed a little bit ago in Spain for bilateral treatment. But the concern is, while this is non-incisional, this is something that you are still causing a lesion, and it would not be, unless we have a much better understanding of the anatomy, bilateral lesions could potentially have the same problems that our treatments had before deep brain stimulation. So still a lot to learn from this therapy, but very exciting. It's also a therapy that that is being looked into to disrupt the blood-brain barrier and allow additional treatment and delivery of medications and growth factors into the basal ganglia and into those patients with Parkinson's disease for additional therapies. Another way to get past the blood-brain barrier is with patients with convection-enhanced delivery, where small catheters are placed. This has been initially used for some brain tumors, but recently there's been quite a bit of interest in patients with Parkinson's disease, where multiple catheters are placed into those structures we talked about, into the basal ganglia, and growth factors are delivered to these areas that have been found to be neuroprotective in patients with Parkinson's disease. So instead of treatments like deep brain stimulation, where we're just trying to improve the symptoms but not changing the natural history, these would be surgical treatments that are endeavoring to actually change the course of the disease itself and to be neurorestorative. So these have not yet, while this is a DAT scan for the pre and post patients, for the placebo patients, and while that had an increase in uptake showing additional dopaminergic activity, this did not reach a clinical significance. Yet there is a lot of interest in this for both for continued therapy and for gene therapy to try and reverse and actually protect rather than just treat symptoms. So there are a lot of exciting treatments right now for patients with Parkinson's disease. Some of this is our adaptation of technology here. We have on the left, when things come out, when people get excited about them, I would certainly say, and then as we go through, we get a better understanding. I would say we're in the late stages of deep brain stimulation. It can always be better, it can always be safer, but this is a therapy that has been FDA approved now for the last 30 years, has been implanted in well over 100,000 patients, and has really been a beacon of hope and satisfaction for physicians that get to treat patients with that, and a real benefit to patients that, again, have benefited from their dopamine replacement but are now having motor fluctuations. So at that, let's try our questions one more time.